So good evening to everyone. Under the banner of this Up-Aroi, we are just going to start our 26th online teaching class. This is the 9th for the breast session. This will be the case presentation. And we are having the team of MPMMCC Banaras. Presenter is Dr.Ankita Kapoor. She is the senior resident there. And our moderator is Dr.Lincon. He is the assistant professor. So over to you.
So good evening, everybody. I am Dr. Ankita Kapoor, Senior Resident in MPMMCC and HBCH Varanasi. Today we will be discussing a case presentation on carcinoma breast. And I'll start with a short history, followed by examination, and followed by the relevant questions which are usually asked during the case presentation. So we have only one case. I'll be starting. So this is a 38 years old premenopausal female with 2 children, with the age at menarche 13 years, without any breastfeeding history, no family history. She presented with a painless lump in left breast for 6 months. So proceeding with the question during the history part, how is family history or menstrual history, parity and exposure to hormonal replacement therapy important in breast cancer? So everybody can put answers in the chat box, and I'll be showing the answers in the next slide.
Student can put their answers on the chat box, which is open to everyone.
So the risk factors in carcinoma breast, I'll discuss. It is female gender, age mostly more than 50 years, previous history of breast cancer, family history of breast cancer, benign breast disease, early age at menarche and late age at menopause, late age at first full-term pregnancy, nulliparity or having only one child, not having breastfed, use of postmenopausal hormone replacement therapy, and use of oral contraceptives. So these are all the high-risk factors for carcinoma breast. To determine the risk of breast cancer, we have a Gale model, which is an application based online, which includes all these factors in the calculation of risk, which includes current age of the patient, race, age at menarche, age at first live birth, or if she is nulliparous, number of breast biopsies, atypical hyperplasia, and number of first-degree relatives with breast cancer. So first-degree relatives include mother, sisters, or daughters. Proceeding with the genetic history, some of the genes associated with hereditary breast cancer are BRCA1, BRCA2, P53 Leishmani, P10 Cowden, Peutz-Jeghers, ATM mutation, CHEK2, Fanconi anemia, and PALB2. So the risk with BRCA1, BRCA2 is approximately 10 to 20 times, which is the maximum. So BRCA1, BRCA2 and other genetic testing should be done in home. So the affected family member should be tested first when possible. If there is no mutation in the affected member or it is an uncertain variant, testing others is not warranted. If mutation is identified in the family member, the unaffected relatives can be offered testing for that specific mutation only after genetic counseling and informed consent. So cancer genetic counseling includes...
Sorry, I'd just like to intervene a bit.
Yes.
Am I allowed? So for the students, hello?
Yeah, proceed please.
Yes, for the students, see, for the relevance of BRCA1 and BRCA2, we must remember first its location in the genome. That is the first thing. Second thing is that we must keep in mind is that it is a germline mutation. So it transmits in the family. Third thing we must remember is the difference between BRCA and BRCA2 in the clinical implications. Like what other cancers can be associated with the BRCA1 and BRCA2 in these patients. So we have, as a examinee, you have to keep these questions in mind also. So that's fine. Okay, that's from my side right now. Okay, Ankita, you can proceed.
So genetic counseling includes full pedigree analysis and risk assessment. And there must be a discussion about the personal risk of cancer based on family history, risk of genetic syndromes in the family, appropriate genetic testing and chances of mutation, full informed consent prior to genetic testing, and personalized risk-based screening and prevention options must be given. Indications for referral in high genetic risk patients. So these are the indications when 2 first degree or 1 first and 1 second degree relative in the same lineage are diagnosed with breast cancer below 50 years of age, 3 or more family members with breast cancer at any age, male with breast cancer or ovarian cancer in a relative, patient or first degree relative with breast cancer below 40 years with or without family history, 2 or more cases of ovarian cancer in the family, Ashkenazi Jewish ancestry, and any family history of breast or ovarian cancer, breast below 50 years and ovarian cancer at any age, and if having both breast and ovarian cancer. So now we'll proceed to the clinical examination of this patient. Here the general examination was unremarkable. In local examination, we found 6 into 5 centimeter mobile firm lump in upper outer quadrant of left breast, which was non-tender, not fixed to underlying structures. Skin and nipple areola complex were free. There was no nipple discharge. Right breast had no palpable lump. On examination of axilla, there was a single axillary node in left axilla, 2 into 2 centimeter in size, non-tender, mobile, and firm in consistency, and no supraclavicular nodes were palpable. So now the next question is, how will you examine the breast? So first we'll start with inspection. In inspection, we have to keep in mind the following points: position of the breast, shape of the breast, size, puckering or dimpling, skin over the breast, and nipple and areola. We have to comment on all these points. And inspection is done in 4 positions. The first image is showing the patient with arms overhead. The second position is patient leaning forward. Third is inspection with patient sitting, hands pressed on the waist. Here, skin dimpling can be obvious in this position. And fourth position is in recumbent position with head end up by 45 degrees. Then proceeding to palpation, we have to note the following points during palpation, which is local temperature, tenderness, situation of the lump, number of lump, size and shape of the lump, surface of the lump, margin, ill-defined or well-defined, consistency, firm or hard, any fixity to skin, fixity to breast tissue, fixity to underlying fascia or muscles, and fixity to chest wall. And while palpating, we have to palpate all the 4 quadrants along with the central quadrant, retroareolar area. And the next important thing is palpation is done with the palmar surface of the fingers of hand. Okay, so palpation, first we'll see the temperature over the breast. Then for fixity of the lump to breast tissue, you have to hold the breast with one hand, and from the second hand, you have to move the lump sidewise. Any fixity will be obvious in this examination position. For demonstration of skin tethering, you have to move the breast tissue aside and see for any dimpling or puckering. Skin tethering is usually due to infiltration of the Cooper's ligament. For skin fixity, we have to pinch the skin. In first figure, we can see the skin is not pinchable, and this shows fixity to the skin. In the second figure, the skin is pinchable, which is obvious here. For pudgy orange appearance, we have to press the breast in this position, and the pudgy orange appearance of the breast skin is seen, which is due to the dermal lymphatics invasion. So now testing the mobility of lump for fixity to the pectoral muscle. So we have to move the lump first along the fibers of the pectoralis major muscle with the arms relaxed, and also across, which is 90 degree to the muscle fibers. And then the patient is asked to press her waist with both hands, and by palpating the anterior axillary fold, we can confirm the muscle is contracted, and then again move the muscle along the fiber and perpendicular to the fiber. This will indicate the fixity to the pectoralis major muscle. For chest wall fixity, we have to ask the patient to press against the wall. With this, serratus anterior muscle fixity can be seen. Now the next question comes, how will you examine the axilla for axillary nodes? So these are the 5 axillary group of lymph nodes, which includes anterior or pectoral group, which we can see in this picture, which is anterior to the pectoralis muscle. Then central group, apical group, lateral group, which is along the humerus, and posterior group, subscapular. How to examine each one of these? First, we'll examine the anterior group of lymph node. So we are examining the right axilla of the patient here. So we have to lift the hand of the patient, place our finger behind the anterior axillary fold, and then the patient's right hand will relax on the left hand of the examiner, and examiner's right hand will support the contralateral shoulder of the patient. And then we'll examine the anterior group of lymph node behind the anterior axillary fold. For the central group, the patient's right hand will rest on the left hand of the examiner, supporting the right shoulder, left shoulder with right hand of the examiner. And the central group is palpated against the second, third, and fourth rib. For apical group palpation, the same position will be used, but the patient examiner's right hand will rest on the right shoulder of the patient, and we have to go high above the axilla for apical group. For the lateral axillary group of lymph nodes, we have to examine with the same hand. So till now we were examining with the contralateral hand, but for lateral group, right hand of the patient and right hand of the examiner. And we have to always remember the patient's arms should be relaxed. So this first picture shows the lateral group of lymph node palpation. For subscapular or posterior group of lymph nodes, the examiner should stand behind the patient, and here also right hand of the patient and right hand of the examiner for palpation. So now the provisional diagnosis. So my provisional diagnosis in this 38 years old lady who presented with a large 6 into 5 centimeter breast lump along with a palpable and large 2 into 2 centimeter axillary lump since last 6 months is most probably a case of malignancy of left breast with axillary nodal involvement, clinical staging being CT3N1M0. So the next question comes, what are your differential diagnoses? So here are the some of the differential diagnoses. So first one is malignancy. The points in favor of malignancy: short history of the lump, rapid growth, and no breastfeeding. Other differentials could be acute mastitis, but the patient is not lactating and there is no history of fever. If it is a fibroadenoma, it will be smooth, firm, well-defined, moving mass, which gives appearance of mouse under the breast. The lump will be painless, slow-growing, non-tender, with no axillary node involvement. In case of
Ankita,
sir,
Dr. Ankita,
sir,
could you just differentiate or pinpoint on the T4 if the primary is involving skin, underlying muscle, or how would you differentiate between the two during examination?
sir, skin and
underlying muscle.
okay. So, sir,
Soft tissue.
So for skin, we have to pinch the skin and see the skin fixity.
Please continue. Sorry, please continue.
Okay, sir. So in case of phylloids, the overlying skin will be tense and thin, but without any infiltration. Axillary node is rarely enlarged. If at all, it is secondary to infection, and there is serous discharge through the nipple. In case of galactosele, the female will be lactating, and there will be a firm cystic mass with nipple discharge. In Paget's disease, there will be scaling, crusting, itching, ulceration, and bleeding, and there could be complete destruction of nipple and areola. In case of lymphoma, the nodes will be rubbery and multiple. In case of sarcoma, there will be a long history with unequal consistency without any nipple retraction, and lymph nodal involvement is very rare. So these are all the differential diagnoses. Then we'll proceed. How will you confirm your diagnosis? So here comes the triple diagnosis technique, which includes clinical examination plus mammography and along with biopsy. So when there is a clinical mass, dominant mass, if it is suspicious, we go proceed with the mammogram followed by biopsy. If the mass is not suspicious, we will do a mammography. And if mammography is suspicious, we'll go for biopsy. If not, then FNAC followed by biopsy or observation. Now, what other tests will you do apart from the diagnostic tests? So here comes the role of metastatic workup. Chest X-ray and USG abdomen is the minimum we have to do as a part of metastatic workup. CT chest is usually done if chest X-ray findings are not obvious and if there is any pulmonary symptoms with the patient. CT abdomen and pelvis is usually recommended in stage 3 and above breast cancer as a part of metastatic workup. Bone scan is done in stage 3 and above, which is locally advanced breast cancers. PET scan is not routinely recommended, but it has a higher sensitivity and higher positive predictive value and negative predictive value. Usually it is helpful where standard imaging results are equivocal or suspicious. Now, is there any role of MRI? This being a young female, we can think about MRI to evaluate dense breast in young females. Other indications for MRI is breast cancer in pregnancy, in patients with positive axilla with occult primary, which is not identified with mammogram, then to determine multicentric disease in ipsilateral breast, or as a part of screening of contralateral breast in high-risk patients. In this patient, we did a sonomammography which showed a left breast mass 6.5 into 5.2 centimeter in upper outer quadrant, 12 to 3 o'clock position, 2.1 into 2 centimeter axillary node. Biopsy of the mass showed invasive ductal carcinoma, not otherwise specified, grade 3. The immunohistochemistry showed ER/PR positivity and HER2/neu negative. Chest X-ray and USG abdomen were all normal. Now, how will you...
Ankita, can I interrupt you?
Yes,
regarding biopsy, which type of biopsy you recommended for this patient?
Ma'am, true cut biopsy is usually recommended.
True cut biopsy. What's about opening regarding the ultrasound of axilla? Do you recommend?
Ma'am, clinically we could see a node and sonomammography has also confirmed the axillary node, so it is not mandatory. So now we'll proceed with the staging of this patient. The TNM 8th edition AJCC staging. Here the main difference is LCIS lobular carcinoma in situ has been removed. Other than this, there is TIS, DCIS, Paget's, T1 less than 2 centimeter disease, less than equal to 2 centimeter. T2 is 2 to 5 centimeter and 5 centimeter is T2. More than 5, that is 6 and above, is T3, and T4 is divided into T4A, B, C, and D. A is involvement of chest wall, but only invasion or adherence to the muscle, pectoralis muscle, is not T4. There must be invasion of the chest wall. T4B is ulceration or ipsilateral microscopic satellite nodules or edema, including the pudiorange of the skin, that does not meet the criteria for inflammatory carcinoma. T4C is both the presence of T4A and B, and T4D is inflammatory carcinoma. So the nodal staging, clinical nodal staging, N1 is movable ipsilateral node, N2 is fixed ipsilateral axillary node, N3 is ipsilateral level 3 node, but the main difference we have to note is N2B and N3B. N2B is metastasis in ipsilateral IMN in absence of axillary node, and N3B is ipsilateral IMN along with axillary node. The pathological nodal staging, PN1 is 1 to 3 axillary node positive, N2 is 4 to 9, N3 is 10 or more nodes. And this is the anatomic stage group 1, 2, 3, and 4. Stage 1 and 2 comes under the early breast cancer. Stage 3 and 4 comes under locally advanced breast cancer. Here the final diagnosis is carcinoma left breast, invasive ductal carcinoma, clinical stage T3N1M0, and the anatomical stage grouping is stage 3A, ER/PR positive, and HER2/neu negative. Now the treatment approach, we have two options. We can go with upfront mastectomy with adjuvant chemotherapy and hormonal therapy, with or without adjuvant RT. The other approach could be neoadjuvant chemotherapy followed by surgery which might include BCS or MRM, along with adjuvant chemotherapy and hormonal therapy and adjuvant radiation therapy. Now, what would you prefer in this case, MRM or BCT?
Dr. Ankita,
Sir?
sorry, I think you have had a question. Why is the stage not T4 in your case? Could you answer that?
Yes, sir. So T4 is involvement of chest wall or skin or both. But here it is just a large breast cancer, not fixed to any structure. I had already mentioned in the history. So I'll proceed. So in this case, we should proceed with MRM, it being a large breast and the cosmesis is less, there is less chances to preserve the cosmesis with a BCS. But if the patient is keen on BCS, if she wants to conserve the breast, we can give an option of neoadjuvant chemotherapy to reduce the size of the tumor, followed by breast conservation surgery for the patient. BCS is always indicated, but there are some contraindications. Absolute contraindication is previous history of RT to chest or breast, multicentricity of the disease, if there is diffuse microcalcification, or patient is pregnant first or second trimester where we cannot deliver RT after BCS. Relative contraindication is presence of BRCA mutation, inadequate breast volume, scleroderma or lupus, homozygous for ATM mutation, and positive margin. So what is BCT, breast conserving therapy? This includes lumpectomy with negative margin, along with axillary dissection and adjuvant radiation therapy. Chemotherapy. So chemotherapy regimens are similar in adjuvant as well as neoadjuvant settings. So in cases of HER2 negative, this is taken from the NCCN. The preferred regimen is dose-dense AC, that is adriamycin or adriamycin and cyclophosphamide, followed by paclitaxel 2 weekly, or we can give weekly paclitaxel also. The dose, in case of dose-dense AC followed by pacli, adriamycin is given in 60 mg per meter square on day 1, with cyclophosphamide 600 mg per meter square day 1. This is a 2 weekly cycle for 4 cycles, and this is followed by paclitaxel. This is also 2 weekly for 4 cycles, 175 mg per meter square. In case of adriamycin, we can also go for epirubicin with cyclophosphamide. In HER2 positive patients, the preferred regimen is paclitaxel along with trastuzumab. But the other recommending regimens could be AC followed by dosi plus trastuzumab. Some of the indications for RT following MRM, radiation planning and everything will be discussed in subsequent lectures. I'll just talk about the indications of RT here. In case of chest wall RT, we'll give, if the primary is more than 5 centimeter, that is more than equal to T3 disease, or it has closed margins. Nodal RT, SCF should be radiated if it is clinically N2 or N3 disease, or 1 to 3 node positive with any high risk features. Axillary RT is given if there is a node positivity with extensive extracapsular invasion, or if there is an inadequate axillary dissection, which is usually less than 10 nodes. Now we'll come to endocrine therapy, as our patient is ERPR positive. So what are the options for endocrine therapy? So these are the main hormonal therapy classes, which includes selective estrogen receptor modulators, which are tamoxifen and toremifene, the aromatase inhibitors, anastrozole, letrozole, and estrogen receptor antagonist, fulvestrant. So tamoxifen is usually given, can be given both in premenopausal as well as postmenopausal women. And the mechanism of action of tamoxifen is that it competes with the estrogen for binding to the receptor, antagonizing the proliferative effects of estrogen. So it has an antagonistic action on the breast cancer cells, but it is a partial agonist for uterus and bone. The anastrozole and letrozole are given only in postmenopausal women, as it inhibits estrogen biosynthesis by inhibiting aromatase enzyme, which catalyzes conversion of androgen to estrogen. Fulvestrant is also given in postmenopausal women, and it competes with estrogen for binding to receptor, antagonizing the proliferative effects of estrogen, just like tamoxifen, but it has no partial agonistic action. and it inactivates and destroys estrogen receptors. So it is also an estrogen receptor down regulator. Now, the next question is usually the toxicities of these hormonal agents like tamoxifen and letrozole. So some of the important side effects. Tamoxifen leads to menopausal symptoms, which is usually vaginal dryness, which is very irritating for the patient. And they usually complain of this in the follow-ups. It also leads to thromboembolism and also increases the risk of endometrial cancers. The aromatase inhibitors, they can lead to osteoporosis, cardiac complications, and hot flushes. If the patient is already osteoporotic in the baseline DEXA scan, we might not give aromatase inhibitor. Now, hormonal therapy approaches in women with doubtful status of ovarian function, like if the patient is perimenopausal or there is chemo-induced amenorrhea, or yeah. So in these cases, we have to check FSH and estradiol status. If there is high FSH and low estradiol, we have to treat the patient as postmenopausal, and we'll proceed with the endocrine therapy as postmenopausal group. How to follow up these patients? So as per NCCN guidelines, only history and physical examination is recommended 1 to 4 times per year as clinically appropriate, and for 5 years. And after 5 years, we can follow up these patients annually. In the follow-ups, we have to educate, monitor, and refer for lymphedema management. Mammography should be done every 12 months. Echo is done annually if the patient has received anthracycline-based chemotherapy or Herceptin. In absence of clinical signs and symptoms suggestive of recurrent disease, there is no indication for laboratory or imaging studies. In patients receiving endocrine therapy, during follow-ups, we have to assess and encourage adherence to adjuvant endocrine therapy. We have to check lipid profile, especially in cases of aromatase inhibitors. And if patients are on aromatase inhibitor, we also have to monitor bone health with a bone mineral density determination at baseline and periodically thereafter. So thank you. I'll conclude with this slide. Any questions can be taken up?
Dr. Lincon?
So, Dr. Ankita, you have had one last question is, could you just enumerate what are the questions that could be asked for this case presentation based on history and examination? Then we can come to the treatment you have already pointed out well.
Yes. So in history, usually the risk factors are asked. We have to emphasize upon the menstrual history, the obstetric history, the history about the breastfeeding, then parity of the patient. So these menstrual and obstetric history is important. We have to emphasize upon that.
Along with family history. Sorry.
Family
Along
history,
with the
yes.
family history. That's very
Family
important.
history is very important in this. And in examination, we are usually asked to examine the breast, axilla, and I have already shown the pictures how to examine.
For the students, it's a pet question of the examiners to they will ask you to demonstrate the fixity to the chest wall and the fixity to the pectoralis muscle, and then you need to differentiate between these two. And I must emphasize that fixity to the pectoralis muscle is not T4. You must keep in mind during examination, even if you find the lesion is fixed to the pectoralis, the stage doesn't become T4A. Do you get me? Anybody?
Dr. Ankita, will you take history of the ovarian cancer in family also, apart from the breast?
Yes, yes, ma'am.
It's also very important.
Yes, ma'am. Breast and ovarian cancer.
Dr. Lincon, can you take questions from the
Yes,
chat
ma'am.
box?
Surely.
So I think there was one question on what is the close margin in case of surgery.
Yes. Dr. Ankita, would you like to have answer that question?
Sir, I think it is less than 5 mm.
No, I must
No,
say
no.
that for breast cancer, ink negative is negative margin. For all practical
Hmm.
purposes, ink negative is negative margin. So we right now don't measure in breast cancer. There is nothing like close. Either it is positive or negative. Am I clear?
And proceed for further questions.
So I think Dr. Lincoln, you'll have to take all the remaining questions.
Yes.
So I think there are two more questions. Difference between margins for BCS, MRM, and DCIS.
Yes. So in DCIS, we need to look at the margins. For BCS, it's the same, that it should be ink negative. So a margin of 1 mm is also sufficient. I would say it as margin negative. For MRM, there should be no chance of margin positivity as such. So in that case, it is also ink negative. But for DCIS, generally 5 mm margin is preferred. So in DCIS cases, we must keep in mind, if in DCIS and there is lumpectomy with negative margins, then we have to treat it as a BCS, and we must give if it is high grade, then we must give radiotherapy along with that. But in DCIS, if it has been completely excised with mastectomy, then it is not needed. But we have to consider about seeing the hormonal status. We can consider about the hormonal therapy thereafter.
Okay, now one more good question is, what is the clinical significance of moving the breast lump perpendicular and parallel?
With respect to sorry, with respect to what?
I think this is with respect to direction of pectoralis muscle, maybe.
Yes. So the thing is, if it is, hello,
Yeah, we can hear you.
hello.
Yeah, we can hear you.
So it's basically for fixity, fixity and its direction basically. Hello.
Dr. Vibhay Parekh has asked about the screening guidelines. US Task Force, NCCN. So, what would you like to say on that? I think that was we did not touch that part. So,
Yes.
would you like to touch on that?
Yes.
And ICMR.
There are subtle differences between these guidelines. Like as per the ACR and NCCN, most of them, they recommend to start screening at the age of 40 or 45. But as per the US preventive task group, the start of the age of screening is around 50 years, at 50 years, and they recommend a biannual screening, like biennial screening, like every 2 years. But all others, they recommend an yearly screening. From ICMR perspective, in Indian setting, I am not very sure that how breast cancer screening are going to help in Indian setting, where we are finding it hard to at least treat these patients who are already having diagnosed. We already have been diagnosed, but in Indian setting, still the breast cancer screening can start at 50 years and biannually. Sorry, means every 2 years.
Okay.
With clinical breast examination and a mammography.
If
So,
patient has
does
a
the
family history, then we can start early from age of 35 years. Hello.
Yes, ma'am. So, if there is a high risk family history, then you can start earlier.
Yes.
So, there is a question on, will presence of Paget's disease of the nipple change your staging?
No.
So the mass, Paget's disease with underlying breast mass, should it be T4B?
No.
Then how would you stage it? Could you just elaborate?
if only Paget's disease is there and the lump itself, the invasive disease is not itself invading the skin, then it would not be T4B.
Okay.
So the primary staging would be based on the size of the lesion.
Now we have a question is when should the bone scan be done?
Yes, bone scan is generally recommended in usually in high risk diseases, in high risk stage 2, like more than 3 centimeters of size. And obviously, if the patient is complaining of pain, then also you have to do the bone scan. And apart from that, more than 3 centimeters primary size, we can have the bone scan as a staging protocol along with the preliminary investigations of chest X-ray and ultrasound. But if you are going for a CT-TAP already, then probably it can also guide you for the involvement of the bone.
Okay, now we have got 2 questions more. You are getting a lot of questions. That's very nice. So what are the common questions associated with chemotherapy that are asked in the practical exam?
Yes.
First question of this. So if you can answer that, the next we'll go to the next one.
In questions pertaining to chemotherapy, I can remember one question from my examination days. The pet question of the examiners are the color of the doxorubicin or epirubicin. So can anybody answer that in the chat box? Yes, yes, red is correct. Apart from that, they are basically interested in the combination of chemotherapies and their side effects. Like doxorubicin and epirubicin, they are basically cardiotoxic. So the next question might be, how do you monitor that? How do you monitor cardiotoxicity, but in chemotherapy patients? The next question can be, what is the ceiling dose? What is the dose limiting range of these chemotherapy protocols? Apart from this, in combination chemotherapy, every drug has got its own side effect profile, so we have to remember that also.
If I were the examiner,
doses can also be asked.
Yeah. So, Dr. Lincon, if I were the examiner, I would first congratulate the student for having reached up to chemotherapy.
Yes,
then
definitely.
The common questions would be the role of Ki-67 with chemotherapy scheduling, the role of the histopathology in deciding chemotherapy. Number 2, then what would be the various, as you said, chemotherapy protocols? What are the active drugs used? What are the common dosages? What are their common side effects? Which of the drugs are known to be irritants? Which are vesicants? So division of those drugs. What is the cumulative dose of the various drugs with respect to lung conditions or heart conditions in a patient? What could be a dose modification with respect to a liver or kidney compromise or comorbidity present in the patient? Then what are the common side effects of these chemo drugs? What are the newer molecules? And what could be various contraindications for use of various drugs? So these are the common questions students are expected to know.
And what are the rationale of combining these chemotherapy drugs?
Yeah, definitely. So I think there are now one more question is, could you discuss about APBI?
Yes. First, APBI in APBI first criteria would be that it should be node negative. After you confirm that the nodes are negative, then you reach to the size criteria. So these days the suitable criteria, you have to, all the students, you must remember the suitable criteria of this APBI. So right now it's less than 3 centimeter, node negative, age more than 50 years. And apart from that, previously her ERPR status was also ERPR positivity status was also considered, but newer versions they do not consider ERPR positivity that important. So basically, at least these three. And previously, DCIS was also not in the suitable criteria, but right now, even if the patient has DCIS along with this invasive tumor, you can go for the APBI. So recently, this APBI criteria has changed, and the students must go through that.
Thank you, Dr. Lincon. To the students, I would like to point out that we have 4 more classes scheduled in breast, which will include radiotherapy planning for post-mastectomy scenario, whether it is locally advanced or a large localized lesion or with axillary nodes. Then there is talk on motion management. Then there will be a talk on hypofractionation as well as follow-up of breast cancer and palliative care. So we will be finishing off with breast with these topics.
Dr. Parikh has asked about this APBI with balloon, interstitial catheter, EBRT, and newer advances. All the students must keep in mind that the doses are a bit different in all of these. So you have to, all the students, they have to remember, like in EBRT, the standard dose is 38 gray, around 38 gray. For interstitial catheter, it is around 34 gray. And in electron, like target, it is around 21 gray, single fraction. So like that. The students must remember those doses also.
For all the students who are participating here, I just want to tell, if you have any query or any question which has not been answered here, you can mail me. It will be given through mail also.
So there is one question: is what are the common questions on breast brachytherapy that can be asked?
We have taken one class on the brachytherapy also.
Yeah, I think we had one class.
Yeah.
So, okay, Dr. Ankita, would you like to answer any question, this last question on how would you manage radiation-induced dermatitis, dysphagia, and cardiotoxicity? How would you reduce or manage?
Yes. So, radiation-induced dermatitis. First, we need to counsel the patient regarding the skincare during radiation and also post-radiation, at least for 4 to 6 weeks. So, not applying any soap or oil, local. They have to keep the area dry. And if there is dermatitis, then we can give like gentian violet paint for the wet desquamation, or yeah, for dysphagia. So we'll just counsel the patient for some warm saline gargles or steam inhalation, and it will. We need to reassure the patient that it will reduce after a few weeks.
See,
Yes, sir.
I would like to comment with in this. See, in breast cancer patients, if the patient has been planned well, then we usually do not see these kind of toxicities in the first 2 weeks if you are going for a 3-weekly regimen. But in the last week, definitely there would be grade 1 or grade 2 dermatitis. It is expected. And dysphagia also, we usually see up to grade 2 dysphagia. The patient has difficulty in taking solids, but the patients would be able to manage with the liquid diet or a puree diet. So it's basically just how to counsel the patient. That's very important. And we have to reassure the patient again and again that this is all these are going to go away within a week or 2 after post-radiotherapy. But even if at all you have to use some drugs for dermatitis, apart from the skin management instruction given to the patient at the start of the radiotherapy. If you have to give some drugs, then you can use some, if it is dry desquamation, then you can use some oil-based thing, but the patient must be counseled and emphasized that it must not be on the chest wall during the radiotherapy to avoid the bolus effect of these agents. For dysphagia, in the market, few local anesthetic liquids are also available, lidocaine based, and apart from that, even sucralfate gel might be a soothing agent prior to the meal or food. It's like that. And for cardiotoxicity, it's all depends on the planning, and cardiotoxicity, mind you, is a chronic toxicity. You expect the cardiotoxicity after around 5-10 years, at least 10 years, 10-15 years. So it's like that. Hello.
Yeah, we can hear you. Dr. Shalin sir, are you here?
I'm very much there. Can you hear me?
Yes, sir, we can hear.
Right. So I have a few comments to make about this entire thing. First of all, now, can I have? I just like to. I don't want to go through the slides all over again. But now, for instance, the questions I can see that are coming from the candidates are that apprehensions on how this simulation can happen. So much of the simulated questions have been asked and answered as a part of the discussion, which is good. One thing I thought was we spoke of the general physical examination as being unremarkable. Normally, students get stuck. They start by saying, there is no pallor, there is no icterus, there is no edema, there is no supraclavian lymph nodes, and the pulse and BP and respiratory rate and abdomen and so on and so forth. It becomes quite involved. So one of the things is that there has to be a minimum statement that must be made in these examinations, because some of your examiners are not quite tuned to this language. They would say, is physical examination not important? What do you mean is unremarkable? Actually, it is a complete statement. But say, for instance, the minimum statement could be, the general physical examination is unremarkable in that there is no pallor, there is no, the patient has no icterus, and the patient has, and then you could say the pulse is, never say 72, say what the pulse is, or at least don't make it 72. And you say the pulse is maybe 80 or 90. That's what you would expect a patient to have when she is being examined. The blood pressure, if you measure it, is fine. Even if you don't measure it, don't say 120, 80. Make it 126 by 78 or 84 or 86. It's important to put it that way. And then you say that, well, the respiratory rate, she's breathing easily. There, the breath sounds are normal with no accompaniments. The abdomen is soft. And the abdomen is soft, non-tender, no organomegaly. So this is the expansion. If they say, what all did you do? So this is to that. Apart from it, the rest of the examination, I think, was fine. The question on pectoralis, I think, could be explained slightly better. You see, the pectorals go diagonally from the chest wall up to the humerus, and the humerus and the acromion area. That's how the pectorals go. So when you move it along or across in the relaxed state, if the lump is fixed to the pectorals, it will move along to a lesser extent, but it will move across to a greater extent. When you taut the pectorals, such as by pushing against your waist, both the movement along the pectorals and across will be restricted.
Yes.
But when it is fixed to the chest wall, there will be no difference whether you taut the muscles or not. So this is the exact explanation of why you move it along the fibers, across the fibers, and the difference between taut and not taut. One is vectoral fixation is not T4 as pointed out. So that was the other question there. And I think it was generally a good discussion. The kind of questions that we should know is, there is a difference. Now, this is a T3 disease with an axillary lymph node. One must know the difference between large operable and locally advanced. This is, the two are not interchangeable. Large operable means it's a largish tumor that can be operated. Locally advanced patient tumors usually cannot be operated up front. For instance, if it's T4, skin involvement, chest wall fixity, etc., they would usually require downstaging with chemotherapy. So while large operable can be operated, and then without the possibility of breast conservation, unless you choose chemotherapy, and the tumor is downsized, and then they making sure there are not other features such as multicentricity, etc., and you don't have extensive microcalcification and other contraindications, and the patient can receive radiotherapy, is willing for radiotherapy, facilities are available, then you can aim and go for breast conservation. There are other aspects that you asked in chemotherapy. So what chemotherapy will you choose and why? So, so if you say 4-AC, 4-Taxol, they would ask you, okay, so this was HER2 new negative. Suppose it's HER2 new positive, you added trastuzumab. A common question could be, when you operate this patient, what would be the percentage of pathological CRs? And then you say, well, it is so-and-so percent. So typically, the path CRs are lowest with CMF, which we don't do anymore, CMF or CAF or CEF. We still use this in financially constrained patients for sure. That's typically about 20-25%. When you go to AC Taxol, the figures go typically in the range of 35 to 40%. And if you're using trastuzumab, these would go up to a further 10%, 50 or 60%, and in appropriately selected patients. But the important thing is that although the path CRs are increasing, it does not impact on the overall survival of these patients. So those are the questions that are asked in chemotherapy. A question commonly asked is, would you give tamoxifen and radiotherapy together? And the answer is, I think the answer is no. And the reason is that tamoxifen arrests cells when they go through mitosis, which is counterintuitive insofar as radiotherapy is concerned. So this is how it generally goes. But overall, I have to say that I think the presentation was quite useful because it particularly demonstrated how all the examination is to be done. There was one last question. If the patient has a locally advanced breast cancer, would you do a pelvic examination in these patients, or would you rely to look for Krukenberg tumor, or would you rely on investigations? And usual answer is that they have those large things. You just do an abdominal examination, unless there isn't a suspicion, and then you rely on imaging to tell you if there is presence of metastasis in the pelvis. All right, so that's what I had to add to whatever has been done very well by Lincoln, and of course, our presenting doctor, yes, and of course, Dr. Ashutosh and team. So thank you very much, and just keep it going. This is great.
Thank you so much, sir. Thank you, Dr. Ankita. It was very well explained and very good presentation. Thank you, Dr. Lincoln.
Thank you, sir. Thank you, ma'am.
Active moderation. Thank you, Dr. Ashutosh, for doing all these things and for course coordination. Thank you, Salin sir, for your guidance. Thank you, all the participants, and thank you, Aarti. Thank you, everyone.